Acute gastrointestinal bleeding is a potentially a life-threatening abdominal emergency that remains a common cause of hospitalization. An upper GI bleeding is defined as bleeding derived from a source proximal to the ligament of Treitz. Patients with acute upper GI bleeding commonly presents with hematemesis, which is vomiting of blood or coffee ground-like material, and or melena, which is defined as black, tarry, foul-smelling stool. Hematochezia is the passage of fresh blood or clots from the rectum. Although hematochezia is strongly related to a lower GI bleeding, hematochezia can be associated with an upper GI bleed if it is a brisk bleed, like a variceal upper GI bleed. The initial evaluation of a patient with probable acute GI bleeding includes a history, physical examination findings, and lab tests. It is very important to ask if the patient has had a prior history of GI bleeding, since it is common that the current bleed is from the same lesion. Also, a patient's history can also help in identifying the source of the GI bleeding. For example, a patient with a history of liver disease or alcohol abuse is at high risk of a variceal hemorrhage. A patient with a history of abdominal aortic aneurysm or an aortic graft is at high risk of aortoenteric fistula. A patient with a history of H. pylori infection or NSAID use is at high risk of peptic ulcer disease. When dealing with the physical examination, first question to ask is the patient hemodynamically stable or unstable? Vital signs are a good tool to gauge how much blood volume was lost. If there is a loss of blood volume, in this case from an upper GI bleeding, there will be low preload, which will lead to less blood to be pushed out of the left ventricle, stimulating the baroreceptors, which then activates the sympathetic system, causing tachycardia. If the patient presents with tachycardia at rest, the blood volume loss is approximately less than 15%. If the patient has orthostatic blood pressure changes, this suggests that the moderate to severe blood loss of more than 15% to 40%. If the patient is hypotensive at rest, then one can assume that the blood volume loss is more than 40%. Check for lethargy that is related to reduced cerebral blood flow. Do you know the percentage of cardiac output that goes to the CNS? It's about 10%. Therefore, if you're losing blood, there will be less cardiac output, and therefore there will be reduced cerebral blood flow, causing confusion and lethargy. Look for stigmata of chronic liver disease. This includes jaundice, spider angiomata, palmar erythema, gynecomastia, testicular atrophy, and ascites. Rectal examination is performed to assess stool color, whether it's melena or hematochezia, or if the stool is brown color. Keep in mind that blood clots in the stool is less likely in upper GI bleeding and more likely a lower GI bleeding. What about lab results? A BUN to creatinine ratio of more than 30 is associated with an upper GI bleeding. The increase in BUN level is due to the breakdown of blood proteins to urea by intestinal bacteria. An anatomical approach is an organized way of thinking about the etiology of the upper GI bleeding. Severe or erosive esophagitis is one of the causes of upper GI bleeding. Esophagitis, by definition, is an inflammation of the esophagus, and enough damage affects the vessels within the esophageal lining, and this causes a bleed. Hematemesis is a common presentation in patients with bleeding from esophagitis. But don't forget about esophageal varices. Portal hypertension leads to an increase in blood pressure inside the veins in the lower esophagus. These thin-walled veins balloon, with the added blood and are therefore susceptible to rupture and bleed. And last are Mallory-Weiss tear, which is due to excessive vomiting as well as esophageal cancer. As for stomach causes, think of peptic ulcer disease, and this is related to gastric and duodenal ulcers likely due to either an H. pylori infection or chronic NSAID use. Also, think about severe or erosive gastritis or duodenitis, and these are predominantly inflammatory processes. Portal hypertensive gastropathy, shortly called PHG, is a common finding in patients with portal hypertension, but uncommon cause of upper GI bleeding. You can also see gastric varices from portal hypertension. There's gastric cancer and angiodysplasias, which are the most common vascular anomalies in the GI tract. As for the small intestine, think about malignancy, AVMs, and aortoenteric fistula. The common causes of upper GI bleeding include peptic ulcer disease, gastroesophageal varices, and Mallory-Weiss tear. Peptic ulcer disease is the most common, with most peptic ulcer disease ulcers caused by H. pylori or NSAID use. A Mallory-Weiss tear is associated with mucosal disruption at the gastroesophageal junction, and this is due to repeated episodes of severe vomiting or retching. Less common causes of upper GI bleeding but are high yield for your exams are Cameron lesions, which is due to mechanical trauma to mucosal folds of the hiatal hernia. Doulofoid lesion, which is a dilated aberrant submucosal vessel that erodes the overlying epithelium in the absence of a primary ulcer, and this should be considered if there is a recurrent, often massive bleeding without a clear source. Aortoenteric fistula is a direct communication between the aorta and the GI tract, and hemophilia is bleeding from the hepatobiliary tract, often caused by arteriobiliary fistula from either trauma or liver biopsy. It involves a triad of jaundice, biliary colic, and GI bleeding. The first goal in the approach to upper GI bleeding is hemodynamic stabilization. Two large bore peripheral intravenous catheters, at least 18 gauge, are required to start crystalloid fluids such as normal saline or lactated ringer. If the patient is at high risk of aspiration, especially if the patient presents with altered mental status or a massive hematemesis, an endotracheal intubation is highly recommended. Intravenous proton pump inhibitor is then started before performing an upper endoscopy. If a variceal bleed is considered, octreotide and antibiotics should be started. Octreotide decreases splanchnic blood flow and lowers portal pressure. But why antibiotics? A patient who presents with acute variceal bleed is at high risk of infection, such as pneumonia and urinary tract infection. Initiation of antibiotics is highly recommended in patients with decompensated cirrhosis with an upper GI bleed. If the patient is on anticoagulation and the INR is elevated, vitamin K and 4-factor prothrombin complex concentrate should be administered. When there is a high suspicion for an aortoenteric fistula, especially if the patient has a prior history of aortic graft surgery, CT abdomen with contrast should be performed before an upper endoscopy. Why? Aortoenteric fistula is life-threatening, with a mortality rate of 50% even with surgical intervention. Upper endoscopy is the primary diagnostic procedure for evaluating upper GI bleeding. In non-variceal bleed, an upper endoscopy should be performed within 24 hours. In variceal bleeding, an upper endoscopy should be performed within 12 hours. An upper endoscopy not only determines the cause of the bleeding, but can also risk stratify the patient and provide endoscopic therapy. In acute variceal hemorrhage, endoscopic variceal ligation is the most recommended intervention for hemostasis of active variceal hemorrhage. What is the recommended intervention if an acute variceal bleed is not controlled by medications such as octreotide and PPI and endoscopic therapy? A placement of transjugular intrahepatic portocaval shunt is recommended and is highly tested on your exams. In a patient who presented with acute variceal bleeding, a non-selective beta blocker therapy should be started before the patient is discharged from the hospital. What are the three non-selective beta blocker therapy for secondary prophylaxis of a variceal hemorrhage? The three non-selective beta blocker therapy are carvedilol, nadolol, and propranolol. What is the goal pulse rate once beta blocker is started? The dosage of beta blockers should be increased as tolerated to obtain a resting pulse rate of 55 to 60 beats per minute. In a 45-year-old male patient with a history of decompensated cirrhosis secondary to hepatitis viral infection presents to the emergency room following an episode of vomiting bright red blood. Vital signs at presentation include a blood pressure of 78 over 60 and a heart rate of 120. Another episode of hematemesis occurred in the ER. What is the most appropriate next step? Upper endoscopy, IV octreotide drip, 2 large bore peripheral IV, start propranolol. The patient presents with a possible variceal bleed and unstable hemodynamics. The first step is to insert 2 large bore IV access before starting IV octreotide and IV proton pump inhibitor. Although the mainstay of therapy in a variceal bleed is an immediate upper endoscopy within 12 hours, the patient is hemodynamically unstable and should be stabilized before any procedure is done. Propranolol is not the right answer, since the patient is already hypotensive and has an active bleed. It is only used as bleeding prophylaxis in patients with esophageal varices. 45-year-old man presents to the ER with melena. His blood pressure is 130 over 70 and heart rate of 80. Labs show hemoglobin of 8. An upper endoscopy showed a duodenal ulcer with a clean base and without active bleeding. Which of the following is the most appropriate next step? No transfusion, transfuse to a goal hemoglobin of more than 8, transfuse to a goal hemoglobin of more than 10. The answer is no transfusion. This patient does not require blood transfusion. The decision to transfuse red blood cell is based on the initial hemoglobin level. If the patient is hemodynamically stable without pre-existing cardiovascular disease such as coronary artery disease, a restrictive blood transfusion of less than 7 is recommended. Otherwise, if the patient has coronary artery disease, the blood transfusion is indicated if the hemoglobin is below 8. However, if the patient is actively bleeding, regardless of the initial hemoglobin level, immediately transfuse blood products, but is not necessary in this specific case. In a 45-year-old male patient who presented to the emergency room with melena, a blood pressure of 90 over 60, heart rate of 120, and a hemoglobin of 9, an upper endoscopy revealed duodenal ulcer with active bleeding. What is the optimal next course of action? No transfusion, transfuse to achieve a hemoglobin goal of greater than 10, transfuse immediately. The right answer is to immediately transfuse red blood cell. Again, if the patient is actively bleeding, regardless of the hemoglobin level, immediately transfuse blood products. In a 45-year-old male patient with a history of decompensated cirrhosis due to hepatitis C viral infection, who presented to the emergency room with hematemesis, an immediate upper endoscopy revealed several esophageal varices with active bleeding. Successfully treated with band ligation. Intravenous proton pump inhibitor therapy was initiated. Laboratory studies show a hemoglobin of 9 and a platelet count of 100. Vital signs include a blood pressure of 110/70 and a heart rate of 80. What is the most appropriate next step in management? Propranolol, octreotide drip, blood transfusion. In this case, the right answer is octreotide. Once octreotide drip is started, what is the next best step in management? Propranolol, ciprofloxacin, or blood transfusion? The right answer is ciprofloxacin for 7 days. Antibiotic therapy is started because bacterial infection commonly occurs within 1 week of variceal bleeding. The most common infections seen are spontaneous bacterial peritonitis, bacteremia, UTI, and pneumonia. Why is blood transfusion not the right answer? Since the patient is not actively bleeding, status post band ligation, and is hemodynamically stable, the patient does not require blood transfusion until the hemoglobin is below 7. Now that we have covered our approach to an upper GI bleeding, let's do some rapid fire questions. First question, how is upper gastrointestinal bleeding defined? Upper GI bleeding is defined as bleeding derived from a source proximal to the ligament of Treitz. When is CT scanning and ultrasound indicated for the workup of upper GI bleeding? Indicated for the evaluation of cirrhosis, cholecystitis with hemorrhage, pancreatitis with pseudocyst and hemorrhage, and aortoenteric fistula. Which symptoms are characteristic of upper gastrointestinal bleeding? Hematemesis and melena. Hematochezia is rare and less than 20% in incidence. What is the role of a BNP in the workup of upper GI bleeding? The basic metabolic panel has BUN and serum creatinine. A BUN to creatinine ratio increases with upper GI bleeding, and a ratio of greater than 30 in a patient without renal insufficiency is highly suggestive of an upper GI bleeding compared to a lower GI bleed. What are the major causes of upper GI bleeding? The 3 major causes are peptic ulcer disease, varices, and Mallory-Weiss tear. What is the role of doulofoid lesions in the cause of upper GI bleeding? It is a large submucosal vessel that has become ulcerated, and because of the large size of the vessel, the upper GI bleed can be massive and brisk. What is the role of NSAIDs in the cause of upper GI bleeding? NSAIDs cause gastric and duodenal ulcers by inhibiting cyclooxygenase, which causes decreased mucosal prostaglandin synthesis and results in impaired mucosal defenses. What is the role of proton pump inhibitors in the treatment of upper GI bleeding? The relative efficacy of proton pump inhibitors may be due to their superior ability to maintain a gastric pH at a level above 6, thereby protecting an ulcer clot from fibrinolysis. Thank you for tuning in. If you find this very valuable, please consider subscribing for more high-yield content that can assist you in preparing for your internal medicine shelf exam and Step 2 CK. Our YouTube channel and Instagram offer daily key points to enhance your Anki flashcards or your notes. We provide short-form videos that cover essential concepts and offer guidance on approaching clinical questions. Keep in mind that the USMLE Step 2 CK test comprises 50 to 60% internal medicine-related questions. Scoring well on this exam is crucial when applying for residency programs. Thank you and take care.